for tuning in to this episode of Focusing on You. I am Heather King, the Educational Director of Hope Abounds Cancer Network. We truly appreciate you taking the time to educate yourself, which empowers you to take more ownership of your health. As everything changes, this video with Dr. Gendro, who is a fellowship trained breast surgeon, she has actually moved locations. So in the video, we talked about the fact that she is in the Raleigh, North Carolina area. Now she is located in Lincoln, Nebraska, providing excellent care to patients in that community. All other information contained in this video is accurate and up to date. Once again, thank you for taking the time to empower yourself and better understanding a breast cancer surgeon's role in your healthcare journey.
Thank you so much for joining us for this episode of Focusing on You. I'm Heather Jeter, the Education Director with Hope Abounds, and very excited to have an amazing surgeon and also a friend joining us today. Her name is Dr. Rachel Gendro. Just to give a little bit of an introduction about Dr. Gendro, she is with the UNC healthcare system. Specifically, she's the chair at UNC Rex Breast Care Committee. She sees patients, she helps in so many different ways. You definitely would love to go and look at some of the reviews that she has. She's very, very patient oriented. I've been with her before, and there have been patients that have come up while we've been together and have just sang her praises. So we are grateful here at Hope Abounds to have her today. One thing that I definitely want to say about Dr. Gendro that is very different from some of the other surgeons that you might have or have seen as a patient is that Dr. Gendro is fellowship trained. She actually did fellowship training specifically around breast surgical oncology as a focus at Moffitt in Florida. And this gives her some extra special training to really make sure that her patients are being treated the way that they deserve to be treated. So thank you, Dr. Gendro, for joining us today.
Thank you so much for having me.
We're very excited to have you. So I'm gonna start right into this, and please interrupt me if you want to add anything additional to what I'm saying, okay? As I referenced in your introduction, you are fellowship trained. And I alluded to a little bit about that, but since this is for patients and their caregivers, can you just elaborate a little bit on the difference between a fellowship trained surgeon that, breast specifically, and one that's not?
Sure, yes. So, with school and training, everyone does their 4 years of medical school, and then for general surgery, it's a 5-year program of general surgery. So then if you want to do additional training beyond that is when you would apply for a fellowship. So the fellowship is for breast surgical oncology, like you had mentioned. And so that fellowship is focused just on breast cancer and breast disease. So not only do you have that 5 years of general surgery, which includes breast surgery, you also have a whole year of breast-only training that is on breast cancer and breast disease.
That's a lot. It's a lot of training. That just makes you really good at what you're doing. They don't accept very many physicians into a fellowship training program, correct? So the year that you went through, you were one of
one. So most of the fellowships will take 1 to 2 fellows. So I went to Moffitt Cancer Center in Tampa, Florida. It's on University of South Florida's campus at their cancer center, and they take 1 fellow a year. So I was very, very lucky and very, very happy to be there. It was a great training program.
That's wonderful. So even just in the group that you're in, are you the only fellowship trained breast surgeon, or are there others that are there that are also fellowship trained?
We hired one physician after I was there who's also fellowship trained. So I was the first female, first of all, amongst 20 to 25 men. Only fellowship trained breast surgeon in all of Eastern North Carolina at the time. So now we have one additional fellowship trained surgeon.
That's amazing. We're blessed to have you local enough in this area if we need you, for sure. So Can you take me through the steps? I mean, obviously you're seeing patients and you are chairing some different committees and doing administrative stuff, but I know just from working with you and speaking to you, your focus and passion has always been helping these patients. So a woman or man, men can have breast cancer as well, come into you, and what is sort of the steps of how they could potentially get to you within the healthcare system, and then the process of what happens after they see you?
So, in general, whether it be a breast cancer diagnosis versus any type of benign breast issue, be it, pain, nipple discharge, cyst, any kind of breast issue, that patient usually comes through the primary care physician or their GYN that refers them over. If they had an abnormal mammogram or have already been diagnosed with breast cancer, a lot of times we'll see them after just different steps of the process. So we'll see them, mostly either sometimes they'll self-refer or their friend saw you or their families, saw me and they wanted to come through that way. But most of them it's either their primary care or their GYN that sends them over.
And then once they actually are there and they see you, obviously you said sometimes it can be a benign cyst, which, is probably the best outcome from that. If it's not, say that it is cancer, what exactly are the steps, from the first time that they come with a bad mammogram with you moving forward until, surgery and then even post-surgery?
Yeah, so say someone comes in, they have an abnormal mammogram, there's something seen and a biopsy is recommended. So we'll either perform that biopsy in the office or potentially have radiology perform that biopsy. There's different ways of doing biopsies, so it just depends on what's the best way to see that abnormality. And then get the diagnosis for them and have them come back into the office to really sit for a very long appointment and go over in just a lot of detail. What's your imaging showing? What type of breast cancer is this? There's so many different ways to do surgery now. So we just go through different options. And, a great thing about breast cancer, if you can say that, is there are so many ways to treat it. And folks, for the most part, do really, really well. So most of this is encouragement and reassurance that we've got this. We're going to get you through this. I'm with you every step of the way, and we'll get on the other side of it. And we really just go through, you can have a lumpectomy, usually radiation follows that. You can have a mastectomy, which is removal of the breast with or without reconstruction. You can also do an oncoplastic reduction, and that's when the plastic surgeon and I work together that day. So I would remove the cancer and they would do a lift and a reduction at the same time. So there's a lot of different ways to go about it. So really it's just kind of explaining what it is, different ways of going about it, what the patient is most interested in, and just really walking them through every step.
Right. I mean, and obviously it depends a lot on, you even said in the beginning, even from the biopsy stage, there are different options, right? And it probably depends on what's seen on the mammogram and where it's located at. And same thing when you're trying to talk to them about all of these different options of what surgical procedure is, right? Every single patient's different and might choose something different. So it's nice that, as you said, with breast cancer, nobody wants to have cancer ever. But with breast cancer, there are many more options now than there were even a decade ago. So
Yes, absolutely. We've come so far with this. And, even 10 to 20 years ago, it was basically kind of, everyone had the same procedure and you had more surgery than you needed. And now we know that you could do less and less surgery and still have the same outcome. So we can take less lymph nodes out, remove less of the breast, just do a much better job cosmetically for these ladies and have them still feel whole at the end of it and on the other side of it.
And there's a huge part of that that's super important too. You focused on the mental part. Just mentally and emotionally healing is a big part of the healing process. We've had patients and providers in the past just talk about how it is, women almost feel as if they're losing some of their femininity, which is sad. And sometimes it's hard for them to move forward, even though they no longer have a cancer diagnosis. So it's nice that you're, as you said, holding their hand and helping them through every step of the way. And
Absolutely. And, we can even do nipple sparing mastectomies now, which, it saves their nipple and the skin. And so they still, when they look in the mirror, they still look like themselves. And that's a huge psychological part of it too.
And, with the nipple sparing mastectomies, the data actually does show, though, correct, that if done correctly, that their risk of recurrence and having cancer come back is the same as if they wouldn't have done that, correct?
That is correct. The only difference is in leaving the nipple in the areola, it increases that risk maybe 2 to 3%. So you could still actually get cancer in the nipple and the areola, but it's very rare, 2 to 3%.
And so if a woman does, if she's passed for surgery, are they still getting mammograms because they still have breast tissue there? What is the procedure and protocol for y'all at UNC Rex Breast Care?
Yeah, so after a lumpectomy, then we would do a 6-month follow-up mammogram. As long as that, it looks good, then we're back to once a year. And that's really based on the American Cancer Society and the American Society of Breast Surgeons recommendations. It used to be every 6 months, but that didn't show to help anyone's prognosis or survival. It didn't change that, and we're just radiating them more with the imaging. So we're doing that 6-month follow-up. As long as that looks great, then we're good for once a year at that point.
That's great. So here at Hope Abounds, we've done a lot with genetics in the past, and I know working with you that that has been something that y'all have done there within the practice. Say that someone does test BRCA positive, and we're just going to use BRCA because that's more prevalent than some of the other mutations. So if they come back BRCA positive, what does that mean for your patient and how that would change their care?
Yeah, so that gene incurs a risk of about 87% for breast cancer and around 60% for ovarian cancer. So their risks are so high. So for a young lady that comes in with that gene, with their breast cancer is due to that gene, then we talk about bilateral mastectomies as a potential option. Now, people don't have to do that. Ultimately, the patient is in control, and it's their decision what to do with their body. So I talk to them about all of their options, but that gene means that your risk of recurrence is much higher. Your risk of contralateral breast cancer is much higher. So I have a few patients who they don't want to have mastectomies or just not interested in that. So we will just do 6-month imaging surveillance with them to watch for that potential recurrence.
Right. And I know being at a larger healthcare system, you also have genetic counselors that are available and can help that patient as well as their family.
Absolutely. So we can do some stat testing in the office to get those quick breast cancer genes back to help with surgery, but we'll also do the extended panel for the 83, 84 genes. And if that were to show anything beyond a breast cancer issue, a colon, a lung, anything else, then we would have them see the counselors to really have a formal discussion on their risk for those genes.
That's great. So, we've talked in the past with multiple different physicians and different specialties, how, when a patient gets a cancer diagnosis, it's not just one provider or one physician that's helping them. There are so many physicians along the way. You've spoken a little bit about it, with radiology. You have a radiologist that's helping with the process, potentially a plastic surgeon. Pathology originally is looking at this. So I know being at Rex, you have a huge healthcare system and you're able to incorporate multiple specialties. So basically, I guess it's whatever's needed for that patient. So
it's so nice that we have such a huge team at Rex. It's such a well-established breast cancer program. So we have excellent medical oncologists to talk about potential chemotherapy or anti-hormonal therapy. Your radiation oncologist will guide you through recommendations for radiation after surgery. The plastic surgeons are there, if we need them, we all work together. And then we have our social workers who are just key in, folks, they can't get there because they just don't have transportation or, they don't have any support and they need help. So we have a great social work program. Our nurse navigators are phenomenal. So that's a service line where it's nurses that sit in with every breast cancer talk and diagnosis. They meet all of our ladies, and those ladies get that as another layer of support. So they're there, they have their emails and their phone numbers. any additional thing is needed, they can always shoot them email. So I always want them to feel like they're surrounded by this big team who's got them covered from every possible angle. And we have our multidisciplinary conference every Tuesday where we all get together and review cases. So it's a very well-rounded, very well-established program.
That's wonderful. It's all about improving patient care, every step of the way. So we appreciate everything you're doing. So obviously right now we're doing this virtually. We're towards the end, hopefully, of our stay-at-home orders and changes and phases being rolled out, and because of the whole COVID-19 pandemic. How has that changed how you're seeing patients? And obviously, even y'all dealing with cancer were shut down for a little while. So is there a backlog that you're trying to dig through, and how is that going there at Rex?
Yeah, so, for the most part, we really slowed our clinics down because of social distancing and not wanting to bring a lot of patients into the office to expose people and that kind of thing. So we have definitely incorporated telemedicine into our practice. So folks that, we can do video visits and that kind of thing and order imaging. For the cancer folks, we really didn't stop cancer surgery. So it was very rare that we didn't take someone to the OR for their cancer. Now, elective things were pushed back, fibroadenosis, that kind of thing. But otherwise, we were getting into surgery and having no problem with that. Rex never really ran out of PPE or anything that would prevent us from getting those folks in. So our cancer folks still got their surgeries. And we're going to start to ramp back up for volume again because they weren't doing screening mammograms for a while at radiology, so folks couldn't get their mammograms. And so that's really all picking back up to normal again now.
That's great. And I know that your office is connected closely to a mammography center. And so it's a nice flow for patients, but I am sure they are just working around the clock and late nights and weekends, just trying to catch back up and get these women taken care of. So
yeah, absolutely. And that everybody's still taking every precaution. We all wear masks all day long, every day, and everything is cleaned, between every patient. So very, very cautious with everything.
Yeah, and I think that many of these offices, including yours, they were already taking many precautions before. It's all just been ramped up just a teeny bit. Do you feel like it's changed patient anxiety levels coming into the office with everything with COVID-19? And are patients more willing and apt to do the telemedicine visits like this?
I definitely have a few folks. I'd say it's pretty few, though, that really would rather not come into the office and want to do their visit. Otherwise, folks really want to come in and get their exam done, make sure their imaging is reviewed. So for the most part, folks are wanting to come in to be seen.
Yeah, I mean, they get to see your face. So who doesn't want to do that? But I mean, in all sincerity, how are you going to do a breast exam virtually?
Right.
There's no way with your specialty to really do a full exam. If it was just a primary care visit or something else, potentially you can talk about it, but they need to be there and see you. I personally am happy that things are starting to get back to somewhat of a norm, whatever that new normal is going to be for us. So. Do you think that this will change things moving forward? Do you think, we spoke a little bit about how, even everything that you have now, it technically can be virtual. You can see a lot of the different screening tools now virtually, and some of the groups that you're part of, you're able to do via meetings like this. Do you think that that's going to become more of, the norm moving forward because of what we've gone through?
Yeah, our group meets every week. We have our cancer conferences every week. We have our breast cancer committee meetings every other month. So there are so many meetings that we're all a part of, and I don't see any time soon that we're going to be getting back together. So I think it's going to be like this for a while.
Yeah, I agree with that. But it seems to be working okay to a certain extent, and not exposing anybody to additional risks. So
exactly, yes.
it's kind of nice on the travel front too. You know, not having to physically be there. You're able to do it from your office or wherever. Um, so what would you like women to know? They say, you know, there's been a backlog on mammograms. They're getting a call, something was seen. And what are your words of advice for a woman or a man out there that had a mammogram and they're getting a call back?
So, that's such a high anxiety time for anyone getting called back from, so they saw something on your screening and we got to bring you back for extra images. So that's such a huge anxiety provoking situation, but it's so important to go back for that callback. They're going to do diagnostic images, they're going to do an ultrasound, really evaluate the area, and it could still be completely fine. You could have dense breast tissue that's overlapping. It can look kind of funny on your screening. The diagnostic shows that it's completely normal. So super important to follow through with that. I also recommend everybody have 3D mammograms at this point. So it's just so much better. It's really dropped our callback rates. So we're really seeing those rates go down. They can see everything they need to see with the 3D and they don't have to call you back in. But definitely follow through, early detection is the key. We find these tiny little early breast cancers that are early stage and folks have 98% prognosis rate. So you'll do great.
Right. I know that is a high stress time for any woman. And obviously if something is found, like you said, it doesn't have to be cancerous. It could still be benign or an area where tissue is overlapping. If they can't get in for whatever reason, because things are busier than normal right now, what are your words of advice just during that time for these patients?
Yeah, so we use 3 different radiology sources. So I feel like they really haven't had any issues right now getting folks back in.
Good.
And we're not having any issues with our diagnostics or ultrasound. So they're getting worked in right away. So just, call them back, follow up, make your appointment, and they're going to get you right in.
And if it's not in your clinic, say that it's in a more rural area and these women just have high anxiety, is there anything that you would have words of wisdom for them?
But just, make sure you're following through with your exams and your imaging. And even if you're in a rural area where they, can't get you in for a couple of weeks, that's still okay. Nothing's going to change in a couple of weeks. So still get your appointment done and don't just wait. We have such great technology, even all of the rural sites even have 3D imaging. So you're just make sure you really follow through and take care of yourself.
There's so many patients, I feel like if they hear the C word, I have cancer, they want it out yesterday, which is understandable. And I think, we've tried really hard to always be advocates for patients, but also to let them know that, as you said, it might be a week or two before you can get in to the appropriate person, but it's okay to wait for that appropriate person so that it's handled correctly when you actually are able to get in to see them. There's not going to be a huge change in that tiny window that is going to completely and totally change care. Is that correct?
That is correct, for sure. Even after we see the person and they've been diagnosed with cancer, we usually have to get your MRI done. That takes another week to get done. If we're waiting on genetic testing results, that's potentially another week. So that's a very routine part of just getting all your pieces of the puzzle together. And that takes a few weeks and nothing changes in that time period.
Okay, that's good to know, just from a patient's perspective. So are there any other words of advice that you have for patients or caregivers out there that, are going through this process or could potentially, be a breast cancer patient?
So one thing I would say is if you notice something on your exam and your mammogram is normal, don't stop there. Because sometimes dense breast tissue can hide little breast cancers. So ask for an ultrasound, ask for an additional diagnostic mammogram. So don't just stop if you think something's wrong, go with that gut feeling, so it's usually right. And just really keep a check on yourself. A lot of ladies find their own lumps and, they come in to get their workup done. So that's super important too. And we just all really got to take care of each other and encourage one another.
Yeah. Well, you've always been a patient advocate, and here at Hope Abounds, we've always said, you have to take your own care into your own hands, and you have to be your own advocate for yourself, for your friends, your family, your loved ones, because nobody knows your body like you do. So thank you for reinforcing that, because that's definitely something that we try really hard to reinforce with patients, that they need to take some ownership and responsibility for their own health. So, well, that is the last question that I had for you, Dr. Gendro, and I am so grateful that you took the time out of your busy day seeing these patients, especially because I know how busy you are, to spend some time talking to us a little bit about what a fellowship-trained breast surgeon does, especially one from a very large and prestigious facility like Rex UNC. So thank you for your time. And thank you to everyone out there that has taken the time to listen to this episode of Focusing on You. You can always go to www.hopeabounds.org and find Dr. Gendro's interview, as well as many others that are out there, just about every cancer type that you can potentially be diagnosed with. And also, if you're just a patient trying to learn a little bit more, please visit the website. There's also the Roku and the Apple app. And until next time, everybody stay safe and healthy, and God bless.